Balloon holds until it puncture roughly around 4 to 6 months.
Oh, sorry. Okay.
Okay.
Yep.
At that time, we believe the patient can like relearn the deltoid how to function better, because we know that patient with rotator cuff tear can lift their arm sometimes,
Right.
and these guys cannot. But by easing the pain, probably they're like re-educating the deltoid, and then they can lift their arm.
Right.
The studies are up to the follow-up that we have now is up to 5, 6 years.
Okay.
That was the first study in Slovenia, and then we have another study done in Israel with multi-center study.
Okay.
The results are equal. The results are same as shown in your demonstration. Now, with regard to our patient,
Eran, somebody mentioned, is it being done only in Israel or somewhere else also?
No. It's much more strong in Europe, I believe, than in Israel.
Really? Okay.
Yeah, the Italian, the French, the Swiss guys, now Germany.
Okay.
There are some people who put it on top of repair, like Laurent Lafosse, do the repair and put it on top. Whether it's justified or not, I'm not sure.
Okay.
But the main indication is a patient like this patient, 60 years old, who is actually pseudo-paralytic.
Right.
He has tremendous amount of pain, but passively got perfect range of motion. So if I do a reverse here, he won't be very happy. He lives in the village, he wants to work with his arm, and he wants to lift them high. With the balloon, he probably will be able to do it, but with the reverse, he have a lot of trouble doing so. The only problem in this case that I think the rotator cuff are repairable. Have you seen the MRI?
Not. We just had a brief look.
Can you show us the MRI, please? And zoom in, please. Zoom in.
It seems both the shoulders are affected. You are doing it on the right?
Yes. The other shoulder is painful as well, however, he can lift it up.
No.
And it's not as painful.
The left shoulder is painful, but he can lift it up.
So, go back to the MRI.
So why, if he can lift it and it is painful, why not in the left?
No, the right is much more painful.
Okay.
And he cannot lift his arm.
Okay.
And the deterioration started the last 4 or 5 months.
So you think by this he will be able to lift his arm because of the deltoid?
I believe so. First of all, he has less pain, which that's
less pain on the left side. So that is the main thing. Okay.
That's the main thing.
Okay.
Okay. Can we start? We have no.
So before you do in space, do you try an arthroscopic repair routinely in your cases?
Well, if I think I can repair it, I will try to repair, and I have the in space. I'll have the in space as a backup.
Okay.
Okay. In this case, I think I can repair it. For the demonstration, we will start with the balloon. First of all, let's evaluate the cuff. But if I think I can repair it, we'll start with the balloon.
Yeah.
We'll finish the balloon, take it out, and then continue with the repair.
Oh, okay.
Okay? I don't have camera yet.
Yes?
We have some technicality problem. Do you would like to ask me any questions?
What he's saying is...
Shashank?
Yes?
Any question from the audience? We don't have the tower yet, so we have plenty of time for discussion.
Any questions from the audience? Yes. Pushing down. No. Dr. Nishish, you heard the question? Sorry.
Okay, so let me tell you about my experience so far.
Okay.
My main indication is a patient that has a lot of pain.
Yeah.
He has no osteoarthritis. He has irreparable cuff tear.
Okay.
Okay. And good passive range of motion.
Good passive range of
passive,
motion.
And if he has active, even better. Those patients, if you do a reverse, they won't like it, because you took him from full range of motion to 110, which that's the average of the reverse, and no external rotation. They're not going to be very happy.
Okay.
So that's the main indication. Another indication is a young patient. If I have a very young patient, which the only option I can offer him is a reverse. I won't do a reverse at the age of 40. So I tried the balloon to end time.
Okay.
Another patient is a very ill patient. I had a patient with his severe...
Sorry to interrupt you, Eran. In those young patients, you don't want tendon transfers or anything?
I didn't hear you again.
You don't try tendon transfers in those irreparable cuffs in the young patients?
Well, the results I have experienced and see from tendon transfer weren't that good.
Not that good. Okay. And any experience about those patches we were talking about in the morning?
Yes, I tried to do patches as well.
Which one?
The jacket graft, the graft jacket.
The graft jacket?
And the one by Mytech. The one that we did in Canada.
Okay.
Why are you laughing?
No, because the company, Mytech guy is here. I was just pulling his leg. Okay.
No, they're excellent. All the Mytech instruments are excellent. That's okay. Sorry.
So are you ready? Or we should keep yapping?
Nearly. We're nearly ready. Okay? We just...
Yeah. So Dr. Nishisha wants to know, does your putting the balloon in improves the biomechanics of the shoulder and that's why they start working? How does it work?
I believe by just a minute.
Okay, we'll go to the surgery. We'll talk about it later.
Does it fit? Are you sure that's the correct? I don't think it's the correct. Guys? Yeah, it's not. No. It's not.
0 to 0 मैच करना होगा. 0 है ही नहीं वहाँ पे. स्कोप के ऊपर एक 0 है. भैया.
It doesn't match. It's
There's no 0.
You sure it's the same?
ये Linvatec है. ये किसका है? ये किसका है? Carl Storz और Linvatec दोनों बदल गए हैं.
So there is some a bit of a problem. We're gonna be with you in a minute. No need. Just a slip. Thank you. I hope you can see.
Yeah.
We need water.
We can see some red and white thing there.
No, it's the blue one. That's the inflow. Opa. It's okay. Now the outflow, there is outflow or there is no outflow? Okay, so. So we are inside the joint. The humeral head, that's the longer of biceps. The subscap is missing, although on examination he had fairly good internal rotation.
Okay. Active?
Yeah.
Okay.
He could resist very nicely to internal rotation. Okay, so there is no supraspinatus. No infra, so probably it's worse than it seems in the MRI.
You still think you would like to repair it?
No. Less and less.
Okay, I can ask them to change your evening flight.
You can have a spinal needle. So let's see. So first of all, I'm doing the lateral portal because I need to aim directly to the apex of the glenoid. When I'm putting the balloon inside, let's just focus. Oh, okay, that's better. All right. No. So I needed to aim directly above the apex of the glenoid with the balloon.
So that's the typical mid-lateral portal?
Yes,
Okay.
if the outside camera can show you. Okay, you see I'm from the side. That's the undersurface of the deltoid. Okay, that's the apex of the glenoid. And I want the balloon to be here.
Okay.
Okay, like so.
So those people who say that biceps is always involved in it, the bicep looks so good in this
Yeah.
massive cuff tier.
Yes,
It looks so pristine.
nice. You're right. So are the French guy crazy? I don't know.
I'm sorry?
Take it out.
Who is crazy?
Are the Do we have any French guy in the audience? No.
No, you can say whatever you want.
Need a driver?
Diksha, what are you saying? You wanted to...
Need a driver.
Oh, would you like to check the reducibility, the
Yes.
mobility of the tear?
Yes, yes.
Okay.
A needle driver, please. A needle driver, that's the instrument that holds the needle. This one. Thank you. Okay. May I have a tissue grasper or a suture manipulator?
Ashish, what would you do in this patient?
So, move it.
We have some experience with the arthrospace lat dorsi, and again, if you compare the in-space, the lat dorsi, these, so these are all salvage procedures. There's nothing that is going to restore him to normal. So if you can have a procedure that can buy him 10 years, then so be it. So it's just
possible to
one
repair
means
it.
of getting it done.
I think it's possible to repair it. I'm not sure whether it will hold.
I'm sorry, what did you say, Eran?
I think it's repairable.
Okay.
I'm not sure how much it's going to hold. Let's look at the quality.
Definitely worthwhile giving him a chance, isn't it?
I think at the age of
Yeah.
60,
Yeah, that's...
and if he's a hard labor, has good muscles overall,
Yeah,
let's look from the side.
yeah. You might age a little bit thinking about your flight, but I think you can repair it.
Okay, guys, what we're going to do, we're going to put the balloon, take it out, and continue with our surgery.
So why
right?
not if you think you need to do any releases or mobilize the cuff, you do that and then show us the balloon.
No, when I put the balloon, I don't do any release. That's the
No,
whole
for the
beauty.
eventual cuff repair.
But that's the whole, unless you're in a hurry, the whole beauty that you don't need to do any release. On the contrary,
Okay.
in a way, I'd rather leave it as so, leave the chromium as such, so it will keep the balloon in place.
Okay.
I don't resect the CA ligament, I just leave it as such. Okay, so let's try to put the balloon.
And the biceps? What do you do with the biceps?
I'll cut the biceps anyway.
Oh, the killer.
Just for you, Shashank. Can I have scissors, please? Scissors.
So, are you going to
Arthroscopic
sacrifice the biceps just because you want to put the balloon? Or
No.
Okay.
I'll sacrifice the biceps because any repair I'll do, the longer biceps will be trapped
Okay.
and it cause pain.
Okay. So, but when you do a balloon routinely, what do you do with the biceps?
Usually the biceps are awful, so I cut them.
Okay.
So let's cut the biceps. There it goes.
So you said instead of 6 months, you said it dissolves around in 1.5 years. Is that what you said?
No, you said 1.5 years, I said 6 months.
Oh, okay. So what happens after that?
After that, there is like all of a sudden a bit of deterioration,
Okay.
and then all of a sudden they go back to where they were after the surgery, getting improved and improved, up to 8 months, 7 months, and that's it. So after 7 months, you can say
So
that's as
when
bad
it,
as
it
that's the
dissolves,
best you get.
okay. You want them to throw some reaction scar tissue around it. And,
Exactly.
Okay.
And that's what we usually see. So this is the glenoid. So
have you?
1, 2,
have you
3,
scoped?
4. I'm counting. Shashank, don't.
Sorry,
Don't do it.
I'm sorry. What?
So 1, 2, 3, 4, 5 centimeters, right?
Okay.
Even 5.5, it's 6 centimeters, and I want 1 centimeter medially, so it's going to be here.
So
it's
that
going
you're
to be
sizing the balloon?
yeah.
Okay.
So this is going to be a large, okay?
Okay.
So I need a large balloon.
So what are the sizes available for this balloon?
Small, medium, large.
Okay.
It goes by the width, 40 millimeter, 50 millimeter, 60 millimeter.
And your landmarks are around 1 centimeter medial to the glenoid
yeah,
edge.
over here. I want to put it here. Okay? So, knife 11. Now it's very important that you watch from the outside. Again, needle driver, please.
Eran?
I'm making the hole a bit bigger.
Eran, go a little slow. We have a lot of questions here.
Okay.
Eran?
Yes.
One question here. What do you do to subscap when you put the balloon? Suppose there's a big subscap tier 2.
I repair it.
You repair it?
Yeah, I think it's important for the strength of the internal rotation.
Okay.
It also holds the balloon in place.
Okay.
So I repair it. Okay, may I have the, yes, the large? No. Could you hold the scope? Now, can you, the cameraman, can you show us the table over here?
Eran?
Yes.
Have you scoped these patients after doing inserting the balloon?
Only in cases where they were unsatisfied.
Yes.
So I did scope few.
So what did you find there?
Fibrous tissue. It's like artificial bursa.
Okay.
Okay, so. Can the cameraman show us the table? Is it possible to show us here? Can you see it, Shashank?
We are looking at the back of your nurse.
Okay.
Okay.
So, this is the device. Okay, the balloon is folded here underneath. I don't want to take it out.
Okay.
I'm taking a 50 cc syringe.
Right.
Make sure there is no bubble, no nothing. And put a 50 cc saline. Okay? Oh, now I need to wash the connecting tube. This is a regular connecting tube. Wash it as well. Could you hold it here like so? And again, make sure I have 50 cc of saline. No air bubbles.
Can you just show that balloon delivery device again and just explain it a little more? Yeah.
Okay, so this is the device.
Okay.
All right?
Yes.
The balloon is here. You see the line? There's a very fine line here. I'm not sure you can see it.
Yes, we can see that, yes.
Okay, so that's the measurement I did before.
Okay.
I'm going to put through the deltoid like so.
Yes.
Okay.
Through the lateral portal.
And take off the sleeve.
Right.
And inflate
Okay.
with the syringe I made.
Okay.
Okay, that's the
As
whole
simple
thing.
as that.
As simple as that. Okay? Now, could you be kind enough and hold it? It's very important not to bend the device. So if it's not going easily...
So why don't you put it through the cannula?
There's no need.
No need? Okay.
Very productive.
So this is, you can see that's the sleeve.
Arthrodesis procedure.
Okay?
Why do it arthroscopically?
You can do it mini open.
Arthritic ankle, there are scars from the previous surgeries. There are peripheral vascular diseases. So their open surgery has got much more risk of skin breakdown than an arthroscopically done procedure. The discomfort is minimal. It can be done as a daycare, and that is what we have been doing as a daycare procedure. No further damage to the blood supply of the talus. When we open, probably there is some damage. So probably you get early fusion when done arthroscopically than done by an open procedure.
Try to see as much
The
as
setup
you
is
can
a monitor or a console across the chest or on the same side as the ankle you are operating.
Okay, I'm
in
going to
knee,
take...
we usually put it on the opposite side. In ankle, I has a personal preference of putting it on the same side. Or we have initially in earlier days put across the chest of the patient on a separate trolley.
Okay, now immediately.
Fluid is on the opposite side. There is a folded gown behind the calf.
Just relax.
to leave the ankle free, and a waterproof draping is.
Okay, so you can see that's the glenoid. I'm going medially to the labrum, medially to the glenoid underneath the rotator cuff in this case.
Yeah.
Usually there is no rotator cuff. And then I go laterally looking for the mark. I'm taking the sleeve off. Okay?
Okay.
That's actually the balloon.
Okay. Okay.
Okay?
Okay. So the balloon is extending outside up right under the deltoid.
Yes.
Okay.
There is a sleeve of the deltoid in my way. I better take it out. Take it off. That's a bit. Okay. Is it open? לא, זה פשוט הדלתוid נתפס שם, אבל הוא יברח להצידה. So now I'm starting to inflate the balloon. You can go backward, 40. Go backward and look. Look to the other side. Oops. No. Can you hold it? We just went out of the joint. Sorry guys, you have to bear with us. Okay. So hold it. So it's, you see how it covers the humeral head. I hope we didn't move while doing all this exercise. Hold the instruments here. So now there's special number that I need to get. Usually we do it under 40. Like in a large balloon,
Yes.
we inflate it up to 40.
40 ml?
Yeah.
Okay.
I think we went too early with our. Go back. Just a minute. No. Just beware with the camera not to puncture it. So it pushes us to the back, and it all the way. Okay, no problem. Let me get inside again. Okay, hold this one. So that's the balloon. You can see it sits on the humeral head.
Right.
It's actually pushing it downward, but we need to deflate a bit. So that's not going to be the end point.
So
This
why are you
is
deflating it after?
Because I want the balloon to find its place.
Okay.
Okay, create is a normal space, and then I deflate it a bit, because if we fill it too much, the patient are feeling uncomfortable. It's pushing the head too much downward.
Okay.
Okay, so you see it, how it's fill up all the gap. It took the deltoid to the lateral side, and now if we try to move the arm, you see that's the exposed greater tuberosity downward.
Yeah.
You see how it moves underneath the balloon. The balloon is stable.
Okay.
Okay,
Okay.
clear enough?
Right. That may be okay.
Okay, now I deflate it a bit, hold the position. Usually I release the traction at that point and let the water comes out. Not too much.
Do you check abduction or anything at this point before you deflate?
Usually, yeah, I have a shoulder like arm positioner, and I detach it and move the arm. Here
Okay.
it's a different system.
Okay.
So, can we have the outside look now? The outside look?
Sorry?
Can you enlarge here? Okay, so at this point the balloon is inside. I just break the seal here, lock it, and that's it.
Eran, how do you decide how much to inflate? It just
It's like the company advise you exactly what to do in each different size of balloons.
Okay, so it's like
It's
30
preset. You
ml
have
for
a
the small,
table.
40 for medium, and 50 for
Yes.
large, like that?
Yes.
Okay.
Yes, in a way. Okay, so let's move the arm, you see.
Doesn't bang.
The balloon is there. The greater tuberosity moves nicely underneath.
Okay.
Okay?
Yep.
I try to push the head, humeral head, upward as much as I can. And that's it. That's
Okay.
the surgery.
Huh?
All right? Any questions? I need a coker.
Okay.
Any question from the audience?
Any? We don't know. Any questions?
That's human head.
In the local anesthesia? Yes, yes, yes. You can do it, yes. Yeah, you can do it under local anesthesia, yes. Yeah. Huh? You don't need Siam. You need to measure. And have you done it under local anesthesia?
Yeah, that's what I was starting to say. I had a patient with severe aortic stenosis that
Aortic
she couldn't
stenosis?
go.
Okay.
She couldn't go through general anesthesia,
There you
and
go.
they asked me to do it under local, and we did under local, and she was very good. So
Did you put a scope in, or how did you measure?
no, I did a scope.
You put a scope in
Yes,
under local?
Under
Okay.
local.
Okay. Any other questions?
All right. Tissue grasping.
Has it ever slipped in your experience, the balloon?
Sorry.
Has the balloon slipped while you
Yes,
were...
we had 2 cases that I can recall. How many years are overall?
So,
Roughly 2 cases that I can recall.
yes.
They went anteriorly. And that was before we used to repair the subscap or do any other
So,
procedures.
per op, it's okay. It's under, you can see that it has slipped. How will you know second day post-op the balloon has slipped?
You see,
You
there's,
see?
there's a bulge on the front of the shoulder. Although the
Okay.
patient wasn't complaining.
Okay. So is there any like, do you think you can, I don't know if X-ray will help, I don't know. Yeah. Yeah.
Sorry? Sorry. Again? Oh, yes, we did. We did a study. We put a radio packet, but the problem is it's damaged the balloon.
I'm sorry, say that again?
It's damaged the balloon.
The radio bake die?
Yes, yes.
Okay,
so
okay,
so
okay.
it's not.
Yeah.
Okay? All right, so we go with our repair.
Then
If you have any other question, I'll be happy to answer.
any other questions? Thank you very much, Eran. So you're going ahead and you have removed it?
Yes, yes.
Okay.
I,
Oh.
I used coker to remove it. Haven't you seen?
Oh,
It
you're quick. Okay, I didn't, I was,
So what? It's you know what? It's just a last word. It's very important to know how to remove it.
okay.
Let's say you're not happy with the positioning. You're not happy with the device. I think you put small one to
That's what
bigger
you're
one.
showing.
You just took a coker.
So
put-
what? Yeah,
Coker.
okay,
You puncture the balloon, turn it, and push it outside.
okay,
Okay?
okay.
So, thank you guys.
Thank you very much, Eran, and best of luck if you are repairing it. Are you going ahead with the repair?
Yes.
Okay, but thank you very much. We'll be
Thank
going
you.
off the air and going ahead with the lectures.
Thank you.
Thank you.
Thank you, everybody.
So